All right, this is the last of the many presentations for transfer medications. This one's titled Antiarrhythmics. We're going to be going over 3. And they are amiodarone, lidocaine, and procainamide. I think we're all pretty familiar with the first 2. You know, honestly, the last one, procainamide, it's got very specific indications. I have never used it and have always done my best not to, because it just sounds like a complete monitoring pain. But let's talk about amiodarone. It's also called pacerone and cordarone, and we may be transferring people out of Georgetown or elsewhere that are on a drip of this medication, or even starting it ourselves, right, according to AHA protocols. So its mechanism of action is to block alpha, beta, we talked about those for the pressors, but also potassium channels, sodium channels, and calcium channels. So it does like everything, which is kind of crazy. And it's used to treat, of course, VTAC and VFib, and for atrial fibrillation, where someone has hypotension and you can't otherwise get good rate control with a beta blocker or a calcium channel blocker. People do have adverse reactions to amiodarone, primarily in the form of hypotension, but also bradycardia. So speaking of which, if someone has bradycardia, they're probably not a good candidate for an amiodarone drip because it can lead to complete heart block. Lidocaine is classified as a class 1 antiarrhythmic, and that's because it blocks sodium channels. And by doing so, it suppresses automaticity, or spontaneous foci of beats in the heart. It's used as a drip if ventricular tachycardia is stopped by a lidocaine bolus during the course of CPR. And it is contraindicated with heart block, again, because it will take someone with second-degree heart block and convert them to a third-degree heart block or a complete heart block. It's also contraindicated in Wolff-Parkinson-White syndrome because by slowing the sodium channels within the AV node, it can actually redirect the course of depolarization around the AV node, which happens a lot faster, and so it can increase the heart rate of tachyarrhythmias, and then someone can have just cardiovascular collapse related to that. The last medication, which again, I personally have no experience. I know at Georgetown Community Hospital, we do not even carry it. This medication is called procainamide, and it has an indication for Wolff-Parkinson-White in addition to atrial fibrillation, refractory SVT, and refractory VFib VTAC. So like lidocaine, it's a class 1 antiarrhythmic that blocks sodium channels, but for whatever reason it does so in a different way, such that it helps to slow Wolff-Parkinson-White, but doesn't redirect that conduction down an accessory pathway and cause decompensation for Wolff-Parkinson-White patients. When you use procainamide, you do have to monitor the EKG because it can cause both QT and QRS interval prolongation. You'll know based on the readout. I think it will give you an automated readout, but essentially a QT interval longer than 500 milliseconds is considered long. And if you see that, particularly if you see it changing and increasing as you're using procainamide, you would need to stop the drip or at least call online control. Same thing for the QRS interval, which is typically 120 milliseconds at the upper limit of normal. A lot of people have a bundle branch block and whatever, and that's fine. But if you're using procainamide and you see their QRS interval prolonging, then that's potentially a problem. And you would want to contact online control for that. That's it for this one. Thank you very much.